Oh, hey, Chris.
Hey Chuck, how are you?
I'm fantastic. I'm at the office on a Saturday morning. What could be better?
Oh yeah, absolutely. It sounds like you must have been rounding then.
I was rounding, but my day started. I woke up a little too early, and I happened to wake up just before I got a text from Emily Zoldos, who's winding down her fellowship, and she said, "Just want to let you know there's a Flexor Tunis Invictus." I'm like, "I'm there." So I was going to come in anyways to round, as you said, and I rode early on my bike through the park, which gives me a little trepidation when it's pitch black. Um, and the only weird part about it was there's those kind of swampy areas in the park
Yep.
where there's sort of still water. I felt like I rode, it was like I was driving a car through a bunch of bugs. And
Oh,
it was
oh.
disgusting. But I made it.
One of the things that as is well publicized now, I'm more of an indoor warrior in terms of working out, just because I like the predictability of the conditions. And but occasionally I will go for runs when it's super nice outside or when I'm traveling. That's mainly when I run. And I remember running in Forest Park last summer and just being like, did I swallow a bug? Like, did I like? And I can only imagine how it is magnified in so many ways when you are on a bike.
On a bike, riding as fast as I ride. I mean, come on. And I was kind of doing the bullfrog through the bug storm.
Ugh, ugh. It's funny. So I was talking with one of our partners, David Bergen, who is an accomplished runner and just recently qualified for the Boston Marathon. So congrats to him. And he was
Yeah.
talking about one of the races he'll be doing next year as a bit of a tune-up for Boston. He was trying to get me to do it with him. And I very well might. It's the Napa Half Marathon. And this is going to sound ridiculous to many listening, but my baseline fitness goal is to always be able to run a half marathon without training, which I'm there. Like,
Wow.
I've occasionally just like kept running sometimes, like Forrest Gump. There's one time I was running and it was kind of like a 6 mile loop. And I just said, I'm going to do it one more time just to text David that I did it. And I did, and it's fine. So I was thinking about running that. And then I was like, you know what, David, like you probably are going to be a triathlon guy. And he's like, you should too. I was like, yeah, the swimming terrifies me. I was like, the biking really terrifies me because the number of people that I see, and you too, who have had very bad injuries biking, interactions with cars or just falls or yeah, it scares me. And I think I'm too chicken now at my wise age
No, it's
to
true.
take that up.
It's true. I don't think I've ever had that infinite capacity. My brother kind of is really fit, and when he was in his early 50s, just went and ran the New York Marathon, which was insane to me. He couldn't walk for a couple of days, but he was able to do it. That's not in my DNA. But I will say both joy and pain this morning. So I came in early, worked with one of the overnight scrubs at Big Barnes Hospital, and someone I hadn't seen in like 10 years.
Wow.
And his first question was, "You still playing ball?" I'm like, "No, I'm not."
Oh, that's so, oh man.
Kills me.
Yeah. That must be tough for you not to play ball anymore.
It is. I'm just happy to put one foot in front of the other.
Well, I don't know what it was yesterday. I woke up this morning just feeling a little more sore, and I don't know if it's because I did a bit of a different workout yesterday, or because we were in an all-day plexus. I'm not sure which one it was, but it's probably a combination of the two.
Exactly right. It's probably a combination. When we're done with the pod, my daughter, the runner, is going to go run 8 or 10 or whatever she's going to do. And then we're actually going to dedication of the new basketball courts in Forest Park. This my day is Forest Park. And so I'm going to meet her halfway and I can't run with her. So I'm going to bike with her and then go to this. So it'll be a nice day.
Very cool. And now is running a goal again, or like running again? Is that a goal for you, or is that something that you just decided you're going to shelf?
I'm going to choose my words carefully. Jogging is a goal again. I've been assured I can. The only thing that makes me a little worried is we're getting to that 6 month mark after my knee replacement, and I'm not ready to run or jog. So we'll see. I'm okay.
I'll be seeing your knee surgeon this afternoon for a family gathering, so I will I'll prod him a bit.
Yeah, tell him Gold Farm's not making you look good limping around the hospital.
And publicizing it on the podcast. So, before I wanted to get into, we have a couple topics to talk about today. We do have some, it's the time of the year for fellowship graduation. But before we get into that, I wanted to thank our friends at PracticeLink. The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join Practice Link for free today at www.practicelink.com/ the upper hand. I think the topics are great. We had talked about a couple different clinical topics. I'm not sure which one we landed on, but the fellow graduation theme I think is always fun.
It is. It's like it's a great time of the year, and then as faculty, you're like, wow, here we go again. Like, we've got to start this whole process again. It is great to see how our fellows, at least in our microcosm, our fellows have grown tremendously over the year. As I was doing the plexus yesterday, I popped over and was watching one of them operate, and it was just nice to just see the decision making and the X-rays and like, yeah, you guys have come a long way, and you were great to start, and now I like to think of our fellowship as a finishing school, because we are fortunate enough to get incredibly talented fellows. When they walk into the door, they have different strengths in different domains of hand surgery, and then we just get them all to the same point by the end of it, and it's just great to see the evolution.
Yeah, I think there's a couple of all of that is certainly true, and every fellow has his or her own path. They come with different skill sets, they come with different knowledge bases, but they do really end up in essentially the same spot. And so it's just super fun to watch. It's gratifying to watch. It's fun to watch. And they all, we were talking yesterday. I was in our COH clinic, and then doing at least one case, and just the joy of obviously approaching fellowship graduation is one thing, but you start to see how meaningful they are to each other, and working together is something that you and David get to do on occasion, and I get to do with Lindley. But it's not something every hand surgeon has the opportunity to do all the time, and it really is super fun. So for those listening who have that opportunity, who don't take advantage of it, you should. It's revitalizing, it's fun. But the fellows get to do it some, and they love it.
Yeah, no, I think it's fun to do every time that so David and I have a dedicated Plexus OR day once a month. And I was describing it to our new micro fellow as operating with your annoying cousin that you love. Or I was gonna go big brother, little brother, but I couldn't decide who was who in that scenario. But yeah, it's a fun time, and it definitely brings out the best in each of you as surgeons, and it's great for patient care. It moves cases along, makes decision making better and less stressful. So is that advice number one that you would give, graduating fellows? Is it, for if you're tackling big cases, do it with somebody else or work with a senior partner, something like that?
Yeah, so I'm going to put us both on the spot and say that we're going to give 7 pieces of advice.
Seven. Good
Yeah, we're
Lord.
coming. We're
Seven, like
going to
seven each or like seven
seven
total?
total.
Like
We'll
seven's a
get
lot.
seven total.
I hope
Yeah,
nobody's counting. So that's number one, I guess.
well, that's number one. It wasn't a planned one. I don't know that I have three in my head, but we'll get there. Yes, I think, as I mentioned, Lindley and I get to operate almost every week. But for example, next week we have a pulsization and a hypoplastic thumb reconstruction, two different cases, and those are cases we do together. We don't, we're in the same spot. We don't always operate together, but it does bring so many advantages to ourselves, to the patient. It moves the case along. I think results are better. But it does, operating in isolation is fine, but you miss something, you lose something, and so bringing that partner in, or it could be, I guess, a very close surgical assistant could bring the same level of satisfaction and joy, I guess. But I think operating with a partner is a whole different level.
Yeah, and I think it's obviously not a viable thing for the vast majority of cases, but especially early on, I think if you're tackling a complex case, and it could be like a one-off kind of thing, but if it's a case where you are either not feeling as comfortable, and you want to bounce decision making off of, or you just need somebody else to help keep the case moving along. If it's like a multi-step kind of thing that involves like nerve grafting and somebody harvesting something else, I mean, it makes sense. And I think as a partner, I'd be happy and relieved that a junior person who was starting was reaching out because I think the confidence as a surgeon starting out is a very challenging thing because you want to come across as confident and capable, but the, Achilles heel for a surgeon is overconfidence.
That's well said. And it is a little bit of a balance as one is starting a new practice to engage his or her partners, show the appropriate amount of independence without the perceptions of overconfidence. It can be very tricky, and you have to sort of read the room because you're sort of trying to thread the needle. And then there's the inevitable, why is new surgeon Joe taking so long to do his carpal tunnels? And most people for carpal tunnel will be just fine, but in bigger cases, in complicated distal radiuses, as one example, it may take you a little longer as a new fellow graduate compared to a partner who's been around for 10 years. But people shouldn't give you grief for that. You take as long as you need to take. You overschedule, which is point number two. I
You
think
took
advice
mine.
number
I was
two.
gonna that was my next one. It's perfect.
But take the time that's required to do a great job for the patient. But to the point of advice, overschedule, not ridiculously, but overschedule because it takes some stress off yourself, and the perception that you're slow will be diminished by the fact that you're just scheduling accurately.
Yeah, I think that's completely valid advice and advice that you gave me starting out and I used. And I'm now kind of at that point of figuring out the balance between overscheduling versus underscheduling in order to get just enough cases on, but then also make sure that the next patients are arriving on time without creating it is a very fine line. So Chuck, all the dashboards, my scheduling accuracy is some of it's really overscheduled, and I'm happy because it actually ends up finding a balance. But so that I think that's great advice. Other advice I'd say is that at the beginning, be very micromanaging with regards to how the OR is, set up in terms of, implants that you might need and the availability of reps if you would like to have reps there, because those are things that either you can directly control and make sure that they're done correctly, or you have to make sure that the person who's doing it knows your preferences and just touch base with them regularly. Because even as we've learned, even far out in practice, some of that stuff can slip through the cracks and really affect a day.
Yeah, and it's easier once you're experienced to sort of pivot and switch it up and figure things out. You don't want to be doing a lot of that early in practice because of an oversight by you or by anyone where the correct equipment wasn't there. So I agree. Be very careful about that. Talk through it a lot. Find the person you trust in your new OR to make sure you have what you need. I think that's great advice. Number four, I would say is, outside of the OR, developing a team is incredibly important because you are one part of a team, and your nurse, your MA, your athletic trainer, whoever it may be, is, I would say, equally as critical to what you put forth in your community, how people see you and your practice, and hopefully you had a hand in hiring the person. And you certainly need to work together to figure it out. But getting the right person is incredibly important.
Yeah, I think that's key. I mean, I've just gone through a transition recently, and have been fortunate that the person that we've hired is fantastic, and I'm on my best behavior to hope that she stays for quite a while. I was fortunate enough to have my first MA was with me since I started and was with me for almost maybe around 9 years. So that was a great run, and she kind of uh, our relationship and our working, our ability to work together just kind of grew. So she probably took on more than she should have been just because she's like kind of was there, kind of watching it ramp up. So it's a lot to walk into, but I think um, taking care of that relationship, being a leader, but also leading from the front in terms of being willing to do everything that needs to be done to get a clinic together and making it like a team and less of a hierarchy is really important.
Yep.
I guess at point number five would be to develop a relationship in the community with the therapy groups. Establish yourself in ways that as much as possible. And we talked before in our marketing podcast with Amanda about going and visiting physician practices. But I think finding ways to make inroads with the various therapy groups in your community is very helpful. And I've found that to be an incredibly helpful resource in terms of doing kind of lunch and learn or kind of after clinic sessions where you just go and talk about a topic and get to know them.
Yeah, a good use of your time. And along those same lines, if you have partners that might benefit from your help, whether it's your sports partners doing certain cases, those relationships are, you just have to develop them. They have to grow to trust you. My number six is most of us start with a practice that's a little slow. That can be frustrating. So you can use your time, as Chris just said. But try to find a way to enjoy that time and don't just lament that you're not busier because you will presumably get busy quickly enough, and then you'll miss that time. So do things in that time which you will not have the opportunity to do later, whether that's spending more time with your family. You don't want to be seen as not in the office and not being around, but spending time with the family, developing your practice, reading. The reading and the preparation shouldn't stop. In fact, I don't think I ever read as much as I did during my first year. I over prepared for every case, and that's critical.
I think in the first 5 years, I read for every case, whether it was carpal tunnel, trigger finger. I just looked at the notes that I had. And then this kind of goes back to the people that are in training now. I mean, develop your note taking system. I was just talking with one of our PGY3s. Trey is fantastic. And we were talking about the hardest transition between being a two and a three. And I talked about this with Dr. Aleem, too, our residency director. Two, you're just trying to figure out where your hands are. Three, you're actually tasked with being a primary surgeon in so many ways, and that jump is big. And the preparation needed to get there is big. And I remember struggling, and everybody does, as a mid-level resident, trying to figure out what your note-taking system. And for those that are graduating, you've probably figured out your note-taking system, but continue to fall back on those notes because those are the same notes you're going to use for board preparation when you're going to take your boards. So I think that that's a critical thing is read for every case, even if it's just looking through your old notes, so you're always prepared. Yesterday in the Plexus, I was talking with David, and we were saying how, sometimes a carpal tunnel is more stressful than a plexus. In the way that if something doesn't go perfect in a plexus, there's so many things you could say, well, bad injury. There are only a certain number of people in the country or the world that do this, and they understand how challenging this is. But a carpal tunnel, there's no room for error in a carpal tunnel. You've got to be perfect every time. So that's the bar. So you got to prepare as such.
Yeah, I really like that. And I also like your point, every level from intern, maybe from medical student to intern to residency stages to fellowship to faculty, you're seeing things differently and you're getting different things out of the case. And so that's part of the challenge. That's why it's so nice when we do operate with our fellows in the middle of the night, even if we don't need to be there. For example, a flexor tendonitis, they acknowledge they get something out of it when we're there with them. And I think I still get something out of it. Maybe it's more enjoyment or the moment rather than something technical. But I think every step you kind of reconsider when you're a two versus a three versus a chief. It's just a really fun development process.
That's the joy of surgery, right? It's and being able to see the differences in each case and what you take out of it, for sure. Do you have any final points of wisdom? I will defer to you as the more senior member of this team to close us out.
Um, yeah, I think the if we have a point number seven is you're never on an island, whether that's local help or we both get joy out of the communications regarding case questions and case preparation from fellows from last year's fellows, 10 year ago fellows. I still text regularly with two fellows that do a lot of sports that were 15 plus years out, and that's more of a we all chime in equally rather than looking for advice from one of our attendings. But I think you're never on an island, and the key to that is don't be shy. Maybe share the wealth. Don't text or email the same person over and over and over. But don't be shy because that's what your fellowship mentors are there for.
Yeah, I'm doing a meeting later today with one of our fellowship graduates from a couple years ago, Lauren Wessel, who's been on the podcast. We're going to talk about a case as well as talk about just kind of how interactions with residents and medical students for research and how to work with that. So Yeah, like you're never on an island. Your fellowship doesn't end after 1 year. Clearly, the relationship changes, but don't be a stranger. So hopefully, that's helpful to those that are graduating. Congratulations on finishing what is likely the last aspect of your training. And make sure to acknowledge your mentors as you go through the process. We're gonna have a little graduation dinner for our graduating fellows, in which they have selected a faculty mentor to give a few words. The question came up during the Plexus yesterday whether this is more of a roast or more of a speech, and the answer was yes. So we'll
That's
see. You've been entrusted with speaking for one of our graduates, so we'll see what you come up with, Chuck.
Yeah, it's been low key in the past. I'm not gonna roast anybody. Others might. Yeah, I have an idea on how to roast Adam, so we'll see. Maybe I will. Before we turn clinical, I'd like to thank Checkpoint Surgical that is continuing to expand their biomaterial portfolio with the launch of ACM Shield soft tissue barrier. ACM Shield is a dehydrated placental membrane allograft for use as a protective barrier in surgical applications.
Comprised of the complete intact layers of amniotic tissue and minimally processed to preserve the native structure of the tissue, ACM Shield is an ideal protective barrier and extracellular matrix scaffold for use in a variety of surgical applications, such as nerve and tendon repair. To learn more, visit checkpointsurgical.com.
I might be visiting to learn more about this product. It's a little over my head.
It is it's a little bit of a new thing for Checkpoint. So we'll see how they do with it. It's funny every time that so when we do our Plexus OR days, we oftentimes will call for nerve stimulators. And both Dr. Brogan and I have to disclose our conflicts of interest as we call for said stimulators. David occasionally listens to the podcast. I think not by choice, because I think it comes up on his queue when he's running and for many hours and doesn't have the ability to readily change it. So occasionally he listens to us and provides some, I'll say, feedback to us about the podcast during these long cases. So yeah.
That's funny. Yeah, I haven't heard any feedback, but you guys spend more time together. That's funny. So I think we talked about two different clinical topics. Do you have a choice of which one we will pursue?
Well, it's summertime, so summertime typically means hot and heavy call with high energy trauma, at least in St. Louis. And I'm realizing more and more that I think in St. Louis, we see some real stuff. Like you can see real stuff here of all varieties. I mean, I remember moving here, graduating residency from Manhattan and coming here and saying, I don't even know what these mechanisms of injury are. Like I had to Google what an auger was because it's not how I grew up. Like, it's nothing that I would have seen in Manhattan or Miami. So, you see some real stuff here. You see high velocity stuff. I was talking to one of our trauma surgeons, Mitch Obi, yesterday, and he's like, "Yeah, this place is it's the real deal in terms of mechanism of injury." So I remember a bad case when I was a fellow, a
Wait,
patient who
wait,
actually ended up
wait. Before your case, so let's talk about some of those mechanisms. This is good. This is good stuff. So we have the traditional city trauma, which is MVCs. Obviously, in St. Louis, we have gunshot wounds, we have stabbings, all that stuff. That's kind of that's the
America's a very nice place. All of you that are listening from.
Yes, yeah. And then we have sort of outdoor activities. So we have our share of bike injuries and scooter injuries
All
and
terrain vehicles, four wheelers.
side by sides, which is sort of an ATV, if you ask me. Um,
All activities that my children will not be participating in with my knowledge based on everyone listening to me like that dude is like such a wuss. Like, he doesn't bike, he doesn't swim. Like
you can only minimize risk to a certain degree. Yeah, I think it's the mixture of the city and the rural engagements, and we get it all, which is interesting.
yeah, I mean, honestly, in our multi-center plexus study, the number of people that are hurt by falling trees in Missouri is pretty ridiculous. So we had a roll, like I said, like 4 or 5 people within the span of 6 months were hurt by falling trees. Now, part of that is because they were cutting the trees down for work or whatever. But I mean, that's terrifying. Like, well, so we'll also see industrial type injuries. I remember one plexus was from a conveyor belt. Horseback riding, which is where this other case that I was about to mention comes in. Uh,
Barges. We are on the
Barges. I
Mississippi
haven't had a
River.
barge one in a
Oh,
while.
I've had a lot of barge injuries. Yeah, yeah.
Railroad. There's one of our plexus patients came off of had a railroad accident, a real bad one. Um, and then yeah, the auger I mentioned, that's a farming instrument or a farming machine. Uh, I believe it's used for corn. I'm sound
Sure.
ridiculous
Yeah.
now, but yeah.
And yeah, and then one of the ones which I did grow up in Alabama, not terribly rural, but I didn't have exposure to wood splitters. Wood splitters are one of the worst mechanisms of injury. And for those of you who hadn't seen it, it's worth a Google or a YouTube. And essentially, you put the wood in this machine that sucks it in and splits it with a very sharp device. And hands and wood splitters do not go well together.
Yeah, and then just the classic, oh, it's nice spring or fall weather. I'm gonna get to the wood shop. So there's a circular saw, the table saw, the standard kind of stuff with that. So yes, that's that's the mechanisms of injury that at least we see here in good old San Luis. Um, so anyway, this patient when I was a fellow, she had a very bad radiocarpal fracture dislocation. Um, so the fracture action was largely on the distal radius. So the carpus itself was not fractured, but the carpus was completely dislocated, fell off on the radial side. So and then was completely dislocated dorsally as well. And so she was horseback riding, was having median nerve paresthesias. So this was a case where, what do you think about trying closed reduction in the emergency room? Is there a role for that? And what's your sense of timing on this? Is this if you get a good closed reduction, you send her out, or is this something that you probably should go more urgently?
Yeah, great points. I would say a couple things. First, typically, I think I can say this, they're open injuries. I mean, if it's that big of a trauma, and that big of a radiocarpal or severe enough distal radius fracture dislocation, they're often open injuries. And so that does affect your timing a little bit. I will say, we had this discussion yesterday, not every open distal radius fracture needs to go to the operating room, but the bigger ones with more trauma, A, probably need to go to the operating room, and B, a closed reduction is almost always a good idea. You don't want to slow down things if the operating room happens to be open and you can get there, but you'd like to get things at least better aligned to take some soft tissue tension away, decrease the immediate swelling that might happen, take pressure off the median nerve. All of those are, in my mind, good reasons to likely do a closed reduction.
Yeah, and for pain, I mean, honestly, like with your hand sitting sideways, that that hurts. So when I've seen this, it's been kind of a type one, sometimes for the ulna from that pressure on the ulnar side of the skin with everything falling radially, and other times for the radius itself, sometimes accompanied by a styloid fracture. And we should probably differentiate, and be careful, So there are distal radius fractures with intra-articular extension, in which you will have kind of a very violent injury that will displace the carpus and the distal fragment in a radial direction. Then there's like a true radiocarpal dislocation, which is slightly different beast. But if I guess for this, I'm talking more about a bad distal radius fracture in which the carpus goes with the distal fragment.
Yeah, I think that's a really important point. Radial carpal dislocations are rare. They definitely happen, but they're rare. More likely is a severe distal radius fracture where you sort of have the articular surface going with the carpus, which is 100% displaced. Um, and almost by definition, you have a TFCC tear. Now, that could be a soft tissue only TFCC tear, or that could be a ulnar styloid that's large, and but I think that is what we're talking about. Thanks for clarifying. And that's what we're sort of going to problem solve.
Yeah, so I mean, so we've done a closed reduction. It's reasonable. Do you get a CT scan? I've had people ask this, and I don't feel strongly about it because honestly, it's not going to change a whole lot of what we do. But sometimes it can be helpful if you're, bold enough to go for fracture fixation, right away.
Yeah, I'm never against it. I think for fellows entering practice is probably not a bad idea if you're not 100% comfortable with the bony status. I usually don't get a CT scan in this situation.
So timing wise, if the patient's paresthesias are stable, or potentially resolving with the after the closed reduction and they're feeling better, what's your general, and there's no other polytrauma kind of issues. This is an isolated injury. So what are you thinking in terms of timing?
If it's a closed injury and if you get reasonable alignment, I think you can do it semi-electively. If it's an open injury and you don't have a great reduction. I guess I would say in the first 24 hours, ideally, something like that, maybe even a little faster, depending on the size of the open injury. How do you think about it?
I agree. I mean, I think if the median nerve paresthesias have not gotten better, that changes my threshold in terms of timing. I would probably move it more urgently. I think that if you don't have a great reduction, that soft tissue swelling is not going to get any better, and you might as well just go.
Yeah,
So
and one,
what's
I'm
go ahead.
sorry.
No, please,
W-
after you.
One of doing a carpal tunnel release is typically advisable in these situations, even though it might be a bruised median nerve and not truly a hematoma in the carpal tunnel. But what you don't want to have happen is you do a great surgery, you have great bony alignment, and the patient wakes up without a carpal tunnel release and they still have tingling in their fingers, and then you're going to worry about it.
Mhm.
And maybe if there truly was hematoma in the carpal tunnel, you've done the patient a disservice. So I sort of make it a habit to do a carpal tunnel release as part of the procedure. I'm sure you do as well.
I think so too. I mean, I think that just as hand surgeons, we're more likely to offer that procedure. So I know that in a lot of places, general orthopods and trauma surgeons will be doing this, and they're probably just because they're lower comfort level with doing a carpal tunnel release. They are less likely to do it, and I think that's been borne out in the literature. Um, but I think you never really regret doing it. And I think this is different than kind of the standard, carpal tunnel syndrome patient. The points of compression I think are different. The it's the volar antebrachial fascia that is right underneath the skin of the wrist crease volarly that is super tight in these patients. So while I don't connect the incisions, if I have a volar approach, I will do kind of a separate carpal tunnel incision. I do make sure that I can see that I've fully released the volar antebrachial fascia or the proximal aspect of the transverse carpal ligament, however you want to think about it, directly. And I look and I make sure I pass my tenotomies or another instrument underneath from the palm incision into the wrist or forearm incision to make sure, because I've been burned by that. And I think that's the compressive point. And then you can access whatever hematoma is there, although I agree a hematoma is relatively rare.
Yeah, and these are ones where you need to be a little careful and avoid the temptation to ever slide because the anatomy can be so skewed that you may, it's just a little riskier. But all good points. Um, so you've gotten a reasonable reduction. Let's say you get to the operating room 8 hours later, you do your carpal tunnel release, um, and you're looking at a very unstable distal radius fracture. You're looking at a unstable DREJ. What's your first thought? How do you think about it?
Well, I mean, so I would always, for me, I'd call for my standard distal radius fracture set of choice. I'd also call for a mini frag set in case I needed to do a little bit of fragment specific stuff on the fly. That's just my choice. I mean, if your distal radius set has all the fragment specific stuff that you like. And then I would also make sure to call for your spanning plate of choice because I think that this is one where I have a very low threshold for a spanning plate. Now, listen, spanning plates are not a panacea. I think that there was a period of time in the kind of late 2010s where everybody was doing spanning plates because of the literature that was supporting their use. I think things have settled back. I mean, I don't love taking somebody back for that second surgery, but I do think there's a utility, particularly not in this case. This isn't a polytrauma case, but if it's a polytrauma case and they're probably going to be needing to do some element of weight bearing through that upper extremity if they've got a lower extremity injury too. That is very helpful. And that's where it came out of really in the experience in Seattle that Doug Handel published. And I know the Duke group published about it as well. But I mean, that's the best use of it. But I think it's been used more and more for isolated wrist trauma. And I don't love using it all the time, but I like having it available.
Yeah, it was interesting. I wasn't sure if you'd bring up this point. Um, you can overuse a spanning plate. And I personally believe I've seen that when patients are treated in another city or come here for another opinion, they've been treated with a spanning plate. I have sometimes wondered why a spanning plate was utilized. I think in some ways it can be simpler, I think, to get and hold a reduction, but I don't know that it's a better treatment, and I'm not sure it's always the right treatment. But in a severe fracture, especially with a very small distal radius articular fragment, I think it's an unbelievably helpful option.
Yeah, I mean, my honestly, my default in the absence, like a very complex distal radius that doesn't have a substantial, carpal sub dislocation type component, I like to fix them, and just it's usually not just a volar plate, so to say. They can be more challenging, but even sometimes with a spanning plate, there are components that are better addressed, I think, with some additional fixation, whether that's through K wires or fragment specific fixation. Usually it's the volar lunate facet or that dorsal ulnar corner that can be really well addressed. And sometimes, that radial styloid type split can be very nicely addressed through a separate fixation. So I like to see how things are lying after the closed reduction and then decide, what to do. And if things keep falling off or things don't feel super solid, then I go to the spanning plate. But if I can get, for example, bicolumnar, ideally orthogonal fixation, I think that goes a long way.
Yeah, and I don't mind going both dorsal and volar for a dorsal plate, volar plate, if I think I can get definitive fixation at that first setting. I do think that is less commonly done with the option of the spanning plate. In other words, you get your general stability and alignment with your spanning plate, and then maybe do some more technical moves, either with a volar plate, a volar hook plate, or fragment specific plate, or even K wires. I'm a big fan of getting your major reduction, holding with a spanning plate, and then using K wires.
Yeah, absolutely. I mean, you've already paid the penalty for the dorsal approach with, the spanning plate. You're not doing a formal dorsal, intra-articular exploration normally when you're doing the a spanning plate, but you've already got the swelling and the soft tissues on the dorsal side at that point. But I like the thought about the K wires. So if you come, I'm sorry, I was going to say if you come to doing the spanning plate, technically, how do you address that? Is there one particular type of plate that you use? I know that all the manufacturers now have a spanning plate.
Yeah, and then your choice of the spanning plates. To me, does it go to the second metacarpal or third metacarpal? Does it have a sort of flare mid plate that can allow you to put screws either in the distal radius or the carpus, or is it just a straight smallish plate? Um, I will say I do like a thin straight plate that you can put in with a couple of small incisions. The benefit is you can take it out with one or two small incisions rather than having to open the entire dorsal approach. But in certain cases, it is nice to have that flare mid plate to allow you to put separate screws in. So I'm not wed to a particular manufacturer for this because I think there's different benefits to different plates.
Yeah, absolutely. I mean, I tend to use like a thin, straight 2427 combi plate. That just tends to be my go-to, but I see the benefit potentially. I have not, from what I remember, taken advantage of the kind of those mid-plate opportunities to put some fixation in the distal fragment. I tend to use it truly like an internal external fixator.
Yeah, and I think that's right. But I think depending on the fracture, sometimes that's helpful. And I'll say that occasionally putting a screw in the carpus is helpful if you're just grossly unstable. That has not commonly, but has been really helpful to me. So I don't think there's any necessarily any pearls about how to fixate dorsally.
I think there are a couple. I mean, I think how do you decide between second and third metacarpal distally?
Um, Essentially, without sounding too cavalier, I almost always go to the third, even though some of them are designed to go to the second. I like to have a little ulnar deviation, resting position, which that can be helpful with putting it on the second. But it's just sort of how it sits to me. I don't know that I don't have a particular algorithm for that. Do you?
I don't. I know there have been numerous biomechanical studies trying to look at this. I don't think it matters that much. Not to sound glib, but like it really, I do think trying to get the restoration of radial length is probably the best consideration for me, and I find that's more reliable going to the third. And then I think the other technical pearl is I remember during fellowship learning from I think it was either you or Ryan Calfee that when I fix distally first, and then when you're going to fix proximally, instead of having the hand pronated on the hand table, you take it off of the hand table, bend the elbow up, and have it in neutral forearm position. Because if you fix proximally with the palm flat with the forearm pronated, it's going to push you radially. If you push the position of the plate radial on the radius, And if you supinate, or not supinate, but get them into neutral form rotation off of the table, and for those of you who are watching on YouTube, I'm demonstrating that. It gets you more centrally on the radius, which I think if you're just kind of in the weeds and you're not thinking about it, you'll regret it.
Yeah, and it's not like you have to do the whole case in that position, but
Right.
you're right. I think, and in general, a dorsal approach with a pronated disc radius can present its own set of challenges, and so that is the benefit of fixating at the metacarpal level first, get a screw in a neutral rotation posture, and then finish your fixation, and that can be really helpful. And I think there is a fine line. You do want to get your length back. Ideally, you're not truly distracting the carpus like you might do a little bit with an external fixer. And if you are distracting, it's just a little bit, you can over distract these, and that has been associated with complex regional pain syndrome. So you do have to be a little bit careful.
And you'll pay a penalty with wrist motion down the line as well. But the CRPS is the pressing concern for me. So I totally agree with that. I don't know. I mean, if you look at the literature supporting the spanning plate use, the wrist motion is very good at 6, 9, 12 months. I do think they have some more limitations in terms of wrist motion than if you had not used a spanning plate, but also I think it's part of the penalty of having such a bad trauma too. So I can't say it's the spanning plate itself that's causing that.
Yes, I totally agree with that. So um, my sequence of steps, and I don't doesn't matter if you do your carpal tunnel first or last. I often just do it first to get it out of the way, and I often try to do the smaller surgery, no matter what the combo surgery is. I try to do the smaller surgery first to minimize the risk of,
Forgetting
let's
to
not
do
say
it.
forgetting, but forgetting to do
No, it's
it.
true. I did a case a couple weeks ago. I looked at everybody in the room and said, "Do not let us forget to do the carpal tunnel." And I immediately started to do the carpal tunnel first, just so I wouldn't forget.
So carpal tunnel first, spanning plate second. However you need to get extra fixation, we need extra fixation. If you have a volar ulnar lunate facet and you want to put a little plate there, if you have a larger styloid fragment, you want to put some K wires. That's the next step for sure. And then for me, I'd love your thoughts. And then the last step is, as always, assess your DREJ critically, assess your forearm rotation, and if there's a large ulnar styloid fragment, fix it. And you can fix it with a K-wire in these situations. I don't get super aggressive with open TFCC repair or anything like that, but fix your ulnar styloid with a K-wire, and it can make a big difference.
Yeah, no, I totally agree. I think that assessing that DREJ at the end is critical. As we wrote in one of our papers, that is a critical step of fixing a distal radius fracture. And it's often a step that gets overlooked because I'm assessing that as I'm asking them to bring in the fluoro for the final films. So when I'm working with a trainee I haven't worked with before, I tell them this is what I'm doing as, just don't forget to do this when you're out in practice. And then lastly, we talked about doing the carpal tunnel release. One advantage of doing the carpal tunnel release is that I have no qualms with them now having a block, which oftentimes is very helpful in terms of pain control. Now, that may or may not be offered at your center, pre-op or post-op. If definitely if they've had a pre-op block, for sure, I'm releasing the carpal tunnel because I have no option of assessing neurostatus afterwards. I still have some fond memories of a case during fellowship in which the faculty said go ahead and do a block, and then we didn't do a carpal tunnel release, and I had to have a very awkward conversation of why I couldn't do a thorough neuro exam. It didn't go over well. You can guess which faculty that was.
I can.
But yeah, so I typically will say if you're thinking about a block, which I think can be a good thing from a pain control perspective, for sure, do the carpal tunnel release.
Yeah, the only caveat with the block, and I agree completely about the carpal tunnel, if it's a even more significant trauma than typically having a compartment syndrome in the back of your
Yep.
mind, that would be the other thing to maybe hesitate. But a block is such a wonderful thing that you'd love to be able to do the block.
Yeah, absolutely. And I think that's a really good point about the compartments. So that was a, hot summertime trauma topic. We have probably another one lined up for the next episode.
Yeah. Last question.
Yeah.
Do you have a standard length of time where the plate stays in before you schedule the surgery to remove the spanning plate?
So first off, for the fellows that are graduating, you have your conversation beforehand with the patient that we're probably going to use a spanning plate. Make sure you dictate in your operative note or your progress note that the spanning plate will be used and there is a planned second procedure. Because you just for so many reasons, it's good to have that in the documentation. And then I mean, I typically would say 2 or 3 months. I know that in one of the older series they went 4 months. I think that's a little bit long, to be honest with you. But I'd say probably 2 or 3 months. How about you?
Yeah, what I tell the patient is 3 months. And if there's clear bony healing and patients getting ANSI 2 months or 2.5 months is fine. The beauty of it, especially if you don't have K-wires, is you have them in a removable brace shortly after surgery. And so they're showering and they realize that having a stiff wrist, especially if you can rotate the forearm fully, having a stiff wrist is not that big a deal. So most patients work on their fingers, they work on their elbow, they work on their forearm, and they're okay, and they're not killing you about getting the plate out. And then you get the plate out, and they have one thing to worry about, and that's wrist motion.
Right, exactly. Do you do a little gentle manip as you take the plate out?
Absolutely.
Not
Yes.
too not too aggressive though.
Not too aggressive.
All right.
All right, that was fun.
That was fun. Well, good luck to all of our graduating fellows. And if there are any other topics you want to discuss as you transition into practice, email us handpodcast@gmail.com.
Love it. Have a good day.
You too.